Okay, so I did my research on Pendred syndrome and non-syndromic EVA, in other words, enlarged vestibular aqueduct. So what is, first of all, I'm going to separate EVA and Pendred, and then we'll kind of bring it together later on. So what is Pendred syndrome? It's an autosomal recessive disorder marked typically by congenital severe to profound sensory neural hearing loss. Again, that can change, or that can present differently. We'll get into that later. Vestibular complications, temporal bone abnormalities, and the presence of enlarged thyroid goiter in later childhood. So that's our overall first look at Pendred. So where did Pendred come from, essentially? Like, who discovered it? It was over 100 years ago, a man named von Pendred in 1896. He was the first to actually recognize that this was an entity of its own, not like other disorders or problems that he saw in the past. And he described it in the case of two siblings. They both had congenital hearing loss and goiter. So that was the first time that Pendred was ever discussed. And then years later, that gene that was responsible was finally mapped and cloned, so that we could learn more about it today and differentiate it. So, and then we get into more of the nitty-gritty parts of Pendred. So the gene responsible, it's a biallelic mutations in SLC 26A4, which is a single mutant recessive gene on chromosome 7q22-q31.1. So this encodes for the protein pendrin, which is a chloride iodide pump. You have pathogenic variants found in about 50%, and it can be mutations in both copies of SLC 26A4 or in just one copy, and additionally in a copy of another gene, which is more often the both on the SLC. So less commonly associated genes, one is FOX11, and pathogenic variants are detected in less than 1%. Then you have KCNJ10, which is, again, pathogenic variants detected in less than 1%. So a genetic mutation affects temporal bone anomalies, which can be bilateral EVA with or without cochlear hypoplasia. So in kind of discussing the genetics a little bit more, in the Medeo et al. Study, they talk about in the thyroid, molecular studies have supported a model. We're discussing pendrin here. It's responsible for transporting iodide into the thyroid to be used in the production of a thyroid hormone. So the specifics of transport substrate in the inner ear, that's more unknown. So moving on here. It's, again, called Pendred because of the protein pendrin, and it's associated with a superfamily of anion transporters found in the inner ear, thyroid, and kidney. So what is an anion transporter? According to Science Direct, organic anion transporters are the secondary, tertiary active transporter proteins that regulate anion balance in the body. They are primarily expressed in the kidney and liver and control the excretion of common drugs, toxins, and endogenous metabolites into the urine. So getting rid of those things. Moving on here. The inner ear, when we're looking at the inner ear, we're talking about the stria vascularis and the endolymphatic sac/duct, as well as the thyroid. It can be a hypothyroid or euthyroid, which euthyroid is, I believe, more normal. It's a normal presentation. Moving on here. So the epidemiology of Pendred syndrome. It seems to occur equally in males and females. SLC26A4 accounts for around 4 to 10% of hereditary hearing loss. That exact prevalence is unknown. So again, kind of going back to that Medeo et al. Article, when referencing epidemiology, they describe in 1965 a man named Fraser. He published a landmark study, and he actually described the clinical features of Pendred syndrome in over 334 cases of Pendred. So after he gathered all of this data, he estimated that the prevalence of Pendred could be about 7.5 to 10 cases per 100,000 people. And it indicated that Pendred syndrome may be responsible for up to 10% of inherited hearing loss. So like we see on this slide, it's kind of variable, but up to 10%. As the studies continued, and we broadened our range because this was performed in the United Kingdom, they started performing it in larger places, and they were able to finally apply it to the world population, and finally came to the conclusion that an estimate of around 5% of inherited deafness is actually due to Pendred syndrome, which is very interesting. Let's move on here. So risk factors for Pendred syndrome. A family history of Pendred syndrome. That is a huge piece here. Otherwise, a random mutation may occur. So when we're looking at this clinically, it can have a variability of symptoms within the same family. In a case studied by Jamal in 1995, other family members can have what is determined as like partial Pendred syndrome. So what he considered to be complete was sensorineural hearing loss, goiter, and a positive perchlorate discharge test. What is a perchlorate test? Because that's going to be important throughout this presentation. It's a test that's performed to show how well the thyroid gland uptakes iodine. And that's according to Medscape. And then partial Pendred syndrome, you're not seeing a goiter, but you're either seeing a drop in the perchlorate test or a sensorineural hearing loss. So the perchlorate test is not necessarily a commonly used test, but it is helpful, according to these studies, in the overall diagnosis. It's a tool in the tool belt to eventually come to the conclusion. In 1958, the it was introduced by a team called Morgans and Trotter. They provided clinicians with a means of identifying patients who had the underlying thyroid defect, and that's what often accompanies the biallelic mutations in SLC26A4. So the reason why I say it's not a very common test to use is because this test is considered to have a low specificity, and a significant variation exists in the criteria used for interpreting this test. So moving on here, when we're looking at hearing loss in this population, it can be congenital, a congenital sensorineural hearing loss, typically in the severe to profound range, but it's also been seen to be in the mild to moderate and progressive. Just from my own experience, I actually saw a little girl. She came in for a cochlear implant activation just a few days ago. She's 4 and she's diagnosed with Pendred syndrome, and her sister is as well. She got her surgery for the cochlear implant actually because she already had hearing loss, but then all of a sudden she had a sudden hearing loss that was worse than what she had before, and they were discussing that she actually had a mild to moderate hearing loss previously. So that's just an example of that can be a presentation. They don't have to just be born and then that happens. It's typically prelingual, bilateral, and more severe in the high frequencies. Hearing loss may present with a progressive sensorineural hearing loss with a late postlingual onset. Progression can be quick in early childhood and be associated with head injury, infection, or delayed secondary high drops. So that whole head injury aspect, that's indicative of the EVA that is commonly seen in this population. Actually, a lot of the studies were saying that you will see EVA in someone with Pendred. A low-frequency conductive component with tympanograms has been reported, and you're going to see that in our case later on. You'll see that it happens. They said it's not very common, but it's good to have in your belt of knowledge. When you're looking at the Pendred patient, they're going to have inner ear malformations. It's one of the major characteristics of Pendred syndrome. Mondini malformation, complete or partial, can be seen, but it's not in all of those with Pendred. So it's not a great radiologic marker to be using. So then they do have enlarged vestibular aqueduct. It's found in all of those with Pendred syndrome, according to the Matteo et al. Study. It can be unilateral or bilateral, and it can lead to a fluctuating hearing loss. Again, we know that if somebody has even a mild head injury, that can be the result. Vestibular symptoms are unpredictable. Vestibular dysfunction is seen in about 2/3 of patients and could be mild unilateral canal paresis or bilateral hypofunction. So again, you're not going to be relying on vestibular symptoms, certain symptoms to appear with this population. You're also not relying on a certain configuration of hearing loss. So good to have everything. Good to perform all the tests that you have available to you. So back to the hearing loss real quick. According to the Matteo et al. Study, their reasoning for hearing loss not being necessarily predictable was a result of this is their theory. There's often a bias in which these initial cases described of a syndrome are the most severe presentation, because those patients are the ones that are easily identified. So that could be happening here. The reason why you always hear that I shouldn't say always, but commonly hear that these people will have severe to profound hearing losses, because those are the ones that stand out the most and are most easily diagnosed compared to other things happening. So an important note about goiter and thyroid stimulating hormone, or TSH. Goiter is usually present without abnormal TSH levels in those with Pendred. Why is that relevant? Because it points out the uselessness of thyroid function tests as a screener for goiter in the Pendred population. Again, goiter can present later in childhood and as well as early adulthood. So, medical management of Pendred. Standard treatment for abnormal thyroid function. Imaging will be performed to observe inner ear malformation. Medical genetics consultation. That's a really important one because, again, Pendred syndrome is difficult. It's a difficult one to differentiate. If you had no genetic testing, it can look like a lot of other syndromes. The presentation is not unlike many others. And then the provider will also do thyroid ultrasounds every 2 to 3 years. And they're most likely going to counsel that patient to avoid contact sports or situations where head injury is a possibility after they're diagnosed. So, audiologic treatment of Pendred syndrome. So initially, when they're diagnosed, they're going to recommend repeat audiograms initially every 3 to 6 months to monitor for progressive hearing loss. Afterwards, we're going to do annual follow-ups thereafter. And I say afterwards, after there's maybe more of a stabilization of their hearing. And then rehabilitation, that's important in this population because things are changing very frequently. Cochlear implants can be something that are being considered, so definitely rehabilitation is very important. Hearing aids are an option. Otherwise, again, like I said previously, they are most often cochlear implant candidates despite their comorbidities. EVA, Mondini malformation are not contraindications to implantation alone, and that's a really important thing to remember. We'll get into this a little bit more. Cochlear implantation is a viable option for the Pendred syndrome population. In a study by Van Nierop et al. In 2015, it showed performance of those children with Pendred syndrome was better than the reference group. Quality of life can be improved. So moving on, actually one other mention of cochlear implantation before we move on. Just a reminder, yes, they are good candidates for cochlear implantation, but there's also other criteria that we need to pay attention to. So their age, the patient's age, also their mental and physical health, their duration of deafness is an important factor before they're just going to jump on the wagon for cochlear implantation, and their capacity to be re-educated. Those are all things that are going to be huge considerations. So moving on to EVA, what is it? Well, first of all, let's look at what the vestibular aqueduct is. I know we're all familiar with it, but sometimes it's nice to have a reminder. So it's a passage between the vestibule and the meninges of the brain. Within this, the endolymphatic duct exists. So when the vestibular aqueduct becomes too large, and typically that's greater than 1.5 millimeters in diameter, air-conducted signals are able to shunt away from the cochlea, causing autophonia and hearing loss, often sudden when associated with head trauma. Vestibular hypofunction is common in cases of EVA as well. Okay, for the etiology pathogenesis of EVA, mutations in SLC26A4. So that's something to note here. Importantly, not all of those with EVA present with 2 mutations in SLC26A4, like what happens in Pendred syndrome. Congenital malformation. Symptoms may present at birth, but also may appear later in life as a result of head injury. Although not fully understood, environmental factors and genetics seem to be the cause, and that's a difficult one. When reading the research, there was a lot of different theories on what's happening. According to Medeo et al., again, they talked about a study in 2001 on mice by Everett et al. It's just to better understand a gene's expression is why they did this. So they created a mouse without a functioning SLC26A4 gene. They wanted to understand what the role of pendrin was in the inner ear. So, although these mice have many phenotypic similarities to Pendred syndrome, there were differences in the presentation. They did not have any identifiable thyroid pathology, but their structure and function of their inner ears was different. They developed early onset profound deafness. Their vestibular symptoms were varied. So all of this so far is pretty similar to humans. So as they were developing, their inner ears appeared to develop normally until 15 days gestation. During that time, all the endolymph containing compartments, including the endolymphatic sac and duct, were severely dilated. And so, in some of the mice, actually, too, this resulted in dilation of the bony cochlea, saccule, and semicircular canals shortly afterwards. So all of this, it refutes the hypothesis of some that the inner ear malformation is the result of an arrest in the inner ear's development. Also, another interesting fact, too, there was abnormalities in the vestibular end organs. They sometimes lacked otoconia, or their otoconia were abnormally large. So theories with EVA and hearing loss, there's different ones. They talk about some of them in the Medeo et al. Article. One theory is hearing loss is the direct result of impaired endolymph ionic and osmotic homeostasis or pH regulation. They based their whole theory on the presumption that the role of pendrin in the non-sensory inner ear epithelia is the maintenance of the ionic endocochlear potential of the endolymph. So that's one theory. Another proposed mechanism for the hearing loss is that there's a reflux of the hyperosmolar endolymph from the sac and duct into the cochlear endolymph, and this leads to a disturbance of the endolymphatic homeostasis. Lastly, there's another theory that hearing loss in patients with EVA may result from microscopic intracochlear fistulae that permit the exchange of perilymph and endolymph. Such fistulae would be too small to be detected by MRI or CT, but could definitely suddenly alter the composition of the endolymph. So this last theory is a good one for better understanding sudden fluctuations in hearing loss. And then as well as, all of these theories and combined with just the structural deformities as well. So epidemiology of enlarged vestibular aqueduct. The prevalence is unknown. However, it's believed that EVA accounts for an estimation of around 5 to 15% in pediatric patients. It's more commonly bilateral than unilateral, and the ratio for females to males is about 1.5 to 1, which is a little bit different than what we heard for Pendred syndrome, which it was described as being generally equal when we're talking about females to males. Risk factors for EVA. Really, it's that mutation of SLC26A4 that is definitely a risk factor for somebody. So when we're talking about clinical presentation of EVA, it's important to have an imaging of that inner ear, an MRI and CT. It's actually commonly recommended in children with sensorineural hearing loss, particularly in cases of a sudden loss. That's a huge indication to do that imaging. Hearing loss can be sensorineural, conductive, or mixed. An airborne gap in the low frequencies is possibly due to that third window effect. Progressive, stable, sudden drops, or fluctuating. And again, with vestibular, it's a wide range of vestibular symptoms from anywhere from episodic vertigo to mild unsteadiness. So it's difficult, definitely. I understand maybe why somebody in the clinic wouldn't jump to doing vestibular testing. I mean, you would do it because you want to make sure that everything's okay there, but as far as a differential tool, it's not necessarily going to identify EVA versus something else. So just important to note. Here are some images of MRIs and CTs of people with enlarged vestibular aqueducts. And again, an enlarged vestibular aqueduct is something that's generally greater than 1.5 millimeters. Just so you're aware. So how do they manage EVA? Steroid injections are sometimes utilized when there's a sudden drop in hearing, but it hasn't been proven to be effective for those with EVA. It's often recommended to these patients that they avoid contact sports or things that increase their chances of head injury. So there's that. Audiologic treatment of EVA. Hearing aids with flexible programming. This goes for Pendred syndrome too. I should have mentioned that earlier. You want some wiggle room with hearing aids when they come into the clinic to see you. If you know that they have EVA or Pendred, you will be safe to assume that you need some headroom on these hearing aids because they may have fluctuations in their hearing. So better to not make them spend thousands of dollars to get a new set of hearing aids when you could provide that headroom initially. So hearing aids, great option, but after hearing aids, most likely their hearing will progress, their hearing loss will progress. So cochlear implants are a viable option with this population, and good outcomes can be expected. So referencing in Europe again, they did a study that showed there was no significant difference between the performance of those with Pendred syndrome and those with non-syndromic EVA after implantation. Quality of life improved for the Pendred population and the EVA population after they filled out these questionnaires. Vestibular rehabilitation is definitely important for this population too, because they will have issues when we're discussing vestibular problems. Repeat audiograms initially every 3 to 6 months to monitor for progressive hearing loss, as mentioned before. Back to that study, however, in Europe, their reference group, just to note, it was an unknown cause of hearing impairment. This study overall is promoting the idea to expect high performance in speech scores and quality of life compared to other CI recipients out there with their unknown causes of hearing loss. So really important to note. This is a good study to reference with your patients that do have EVA or Pendred, because how do they know what to expect? This is something they've never heard of before. And so I'm going to definitely keep this study near me at all times, because you probably at some point, if you work with pediatrics, will see these patients. So just talking to their parents about, like, yes, I see that there's malformations in their inner ear, but there's been great success in many studies, especially recent studies, for these patients in cochlear implants. So main factors that may influence cochlear implant outcomes: intraoperative risks of gushing or oozing of cerebrospinal fluid or perilymphatic fluid, as well as postoperative vertigo. Again, these are the things that were found in the May et al. Study that did influence outcomes, but it's not quite enough to, it wasn't common enough to be like, this is not a good idea, we shouldn't do this. So now for like the point of this whole presentation, aside from understanding these disorders better, is how do I know, just as an audiologist, the difference between Pendred or non-syndromic EVA? Not just an audiologist, but for the doctor as well. Pendred syndrome patients will most likely present with a euthyroid goiter in later childhood, while the child with non-syndromic EVA will not. This is where the perchlorate discharge test, in combination with other clinical measures, may provide differential information between EVA and Pendred. Going back to our Madeo et al. Study, there was a finding of one SLC26A4 mutation in 11 of 18 patients, so about 61% with non-syndromic hearing loss in EVA. It's far greater than what would be expected based on any kind of chance alone. So when DNA from both parents was available, one unaffected parent was always found to be a carrier of the SLC26A4 mutation, and that was identified in the affected member of the family. So all of this is suggesting that one SLC26A4 mutation may contribute to EVA and hearing loss, but it's not sufficient to cause Pendred syndrome. So we're about to be talking about genetic testing again. This is super important, and this is probably what the doctor is going to be looking at. Yes, so that's just an important thing to have noted. Molecular genetic testing is essential. So as mentioned previously, and what I just mentioned now, patients with Pendred syndrome typically have biallelic mutations on SLC26A4, while those with non-syndromic EBA tend to have one. And you're not going to see just one mutation in those with Pendred. They'll also use thin-cut CT, and they're going to definitely discuss family history of Pendred syndrome. Before I move on, I just want to make sure I don't have any other important notes here. Yeah, I think that's covered there. So again, you're not going to be just seeing certain patterns of hearing loss with this population. You're going to see a variety in both Pendred and EVA when we're looking at the audiogram. Both can have sudden. The patient that I saw in clinic had Pendred syndrome, and hers was a sudden hearing loss. She also began with mild sensorineural hearing loss, and then it progressed from there. Her sister is not quite wearing a cochlear implant yet, but she most likely is going to. We're actually going to assess her next week, I think. And they're both performing well, but there's always that chance. The one that we saw for the activation was 4 and her sister's 6, just for reference. So onto a case study. This case was retrieved from OddSim, and it was donated by Charlie Mowbray, who's an audiologist. So if we're seeing this child come into the clinic, she was a 20-month-old female, and there was concerns of speech and language development delay. She had not had a speech and language evaluation yet. This is super, super common. I see kids coming in all the time for speech and language delay. So far we don't know anything. This seems like any other routine evaluation. Her birth history was unremarkable, so she was not born with a hearing loss. I mentioned right here past newborn hearing screening, and her medical history was unremarkable. I'm assuming, aside from medical history, they were saying family history. They didn't mention that in this case. So we do an evaluation, and we do tympanograms, and we see that she has type A normal tympanograms in both ears, and that's to be expected because this disorder or these disorders aren't going to have a conductive problem. Most of the time it's sensorineural, and if you are seeing ear bone gaps, they attribute that to the third window issue. So again, nothing's really standing out, pointing towards anything yet. We're seeing type A normal tympanograms. OAEs, though, they're absent in both ears. So that's our first abnormal finding. We attempt conditioned play audiometry, but she's unable to be conditioned. So next we do a sedated ABR. So if we're using the Bagato 2006 conversions, which as a reminder is minus 20 dB at 500 Hertz, minus 15 dB at 1000 Hertz, minus 10 dB at 2000 Hertz, and minus 5 dB at 4000 Hertz, we see a possible moderate sensorineural hearing loss in the right ear and a mild moderate sensorineural hearing loss in the left ear. So if this patient was in my clinic, I'm not sure that we would have jumped straight to a sedated ABR. I find it kind of interesting that they just didn't waste any time. I'm not sure whether this audiologist works, but just from my experience, we probably would have brought them back to do conditioned play audiometry again, just to see. I actually think now that I think about this is very interesting that they decided to do CPA because she's 20 months old. Just having this realization now, they should have maybe done VRA? That's strange. I'm just going to pretend like they tried VRA. Moving on. The patient is referred to ear, nose, and throat. Findings are negative for middle ear pathology, because we know that people can have middle ear pathology even with atympanograms. So that's good that they did that. They did genetic testing, MRI, ophthalmologic evaluation, and a repeat ABR were recommended. Again, I find it's very interesting that they didn't do VRA at 20 months. Not even 2 years old yet. That must have been a typo. Okay, anyways. Okay, so now here we are at 21 months. The ABR is completed at a different facility, and this time it showed the left ear having a severe rising to moderately, possibly mixed hearing loss. The right ear is showing a severe to profound sensorineural hearing loss. A trial with amplification was recommended. Speaking of this trial with amplification, I know you all can't respond to me right now, but I wonder what your thoughts would be of doing a trial with amplification at this initial evaluation at 20 months, just because I understand that we need to repeat what we're finding, but I don't know. What would your decision be? An MRI was performed, and it showed a large vestibular aqueduct on the left side without cochlear malformation. Vision tests are normal. Genetic testing, so far it's showing it's normal for GJB2, connects in 26, and GJB6, connects in 30. Yes. So one of the articles mentioned that when they go ahead with genetic testing, they need to specifically be wanting to analyze. They're looking for something specific. So just because they do genetic testing does not mean you're going to find every single possible thing that could be wrong with them. So she's back at 22 months. The left ear is looking better than the most recent ABR. However, the right side looks similar. Those aided thresholds are showing great benefit. So at this point, she's enrolled in auditory verbal therapy. They did not say if I'm assuming she came in for, she's now able to be conditioned for hopefully VRA. Evaluation at 24 months, her hearing's stable. So they do some aided testing of ling sound thresholds. So what they found was oo, ah, e, and sh were coming in about 20 dB, and S sound was coming in at 25 dB. So that's great. Mother reports the patient has sound confusions, like the difference between tiger and tire. At this point, the recommendation is to monitor for hearing fluctuations and further genetic testing. So interesting that they did not suspect or to test for Pendred syndrome initially. So now she's 2. She comes back at 26 months, and we're seeing a low-frequency hearing fluctuation with loss progression and an airborne gap. As mentioned before, the airborne gap can be a result of that third window. 27 months, we're seeing stable hearing. 28 months, that further genetic testing shows Pendred syndrome. Urine testing is negative for Alport syndrome. They do an EKG, and it's negative for signs of Jervell and Lange-Nielsen syndrome. So the recommendation here is let's refer to an endocrinologist for thyroid function evaluation, even though thyroid issues typically arise later in childhood, because again, she's only 28 months at this point. Now she's back at 29. A little fluctuation happening in that right ear. Her tympanograms are normal, and aided thresholds are still great at 20 to 25 dB. So now she's back at 30 months. Unfortunately, she's not making significant progress on speech and language development, despite her great aided thresholds. Like, those are really good. And she's in auditory verbal therapy, but she's only about 10% intelligible to her parents. So at this point, they recommend an evaluation by a cochlear implant team, and they recommend a right implant. This is where the case study ends. The parents are unsure. They're not sure whether to move forward with the cochlear implant. Just a good takeaway to think about or reflect on is maybe how would you counsel the parent if you were the CI audiologist? What would be some things that you would say? But in the end, this case, if it were me without the genetic testing, I would not know. So that is important when you see these kids coming in and there's no explanation. Genetic testing. I know we can't recommend that or we can't prescribe that, but it just shows the importance of that information. There's no way of really knowing what's happening otherwise, aside from you would know if they have EVA, but you wouldn't know if they had Pendred because genetic testing is really important. So imaging and genetic testing, that is what's going to help us. They may do that perchlorate discharge test that we've kind of seen. It's okay, but why not try it in our battery? Because in some cases it can definitely point us in the right direction. Thank you for listening. I will let you all know what happens with the current Pendred syndrome case that I'm seeing in clinic. And yep, that is all.